Right, I guess wait just a few moments till everybody's here. Here, I guess it's give it one more minute and we'll get going. Mahmoud, how's it going in California?
It's going well. Good morning.
Good morning.
Lots of learning.
Sure. Send my regards to Dr. McElhaney, Dr. Seresnek, Dr. Dubin, Dr. Lopez, all my buddies. Lots of very good friends there.
Will do. Yes.
Thank you. Well, since today is 9/11, I just want to take a moment and pause in memory of all the people who died on that terrible day. 22 years ago, I actually was giving grand rounds on electrophysiology at St. Vincent's Hospital, which doesn't exist any longer, but was actually the hospital that was physically closest to the 9/11 site, and actually saw the second plane hit the tower as we were exiting my grand rounds, which was from 8 to 9 in the morning. So very sad day in New York history, in our country's history. And I lost a friend that day. My friend Joseph Hassan, who was a classmate of mine in high school, was unfortunately died in one of those buildings. So anyway, to their memory. So today I thought we would start with a discussion about this case. So this is an A-wire tracing in a patient who is a post-operative tetralogy patient. So why don't we start with Maya? Maya, what do you think we're seeing here? I think V5 in this example is the A-wire tracing.
All right. Okay, so I guess first off, like knowing that this patient is post-op tetralogy of full low, be suspicious for jet.
Absolutely.
And so looking at the A-wire, so it looks like we do have AV dissociation.
Is the atrial rate faster or slower, you think, than the ventricular?
Like the atrial rate is slower than the ventricular rate. And it probably, this patient is post-op TET, so does probably have a right bundle branch block. So I'm going to go ahead and say that this is most likely a junctional tachycardia.
That's right. So so I very much appreciate the way that you thought about this, and that's very important, which is you started off by saying this is a patient who has tetralogy and has a rapid heartbeat. And so even without looking at the tracing, right, you could at least guess that maybe that's what this would be. And so in general, what I often say is if there are more V's than A's, usually you're either in VT or jet. And so, and you appropriately and correctly wondered aloud as to whether or not the QRS was the usual QRS of the patient or not. And I think it's a reasonable assumption that a postoperative TET patient might have a bundle branch block, but of course you don't know that for sure. So how would you tell, Maya, if this patient, why does it matter? I should say first, if this is a the patient's usual QRS or if it is a wider QRS than usual.
Well, if it's a wider QRS than usual, then I'd be concerned for ventricular tachycardia, which would, I guess, not entirely unexpected, but perhaps a little bit more unexpected than jet. And we might treat that differently.
Yeah.
So I would look for, or I would look towards, the prior EKGs or the prior telestrips to look at what the QRS had looked like before.
Right. That's good. Although, of course, oftentimes, so one of the reasons why I often say it's important to get a 12 lead fairly soon after arrival from the operating room is it's unusual to see jet immediately after surgery. It can happen, but usually you're not in jet either because it takes time to happen or because the anesthesiologist has treated it already. And so it's useful to look at that initial EKG, but sometimes we don't have one. Sometimes the patient comes back in the arrhythmia. And of course, the QRS may look very different after surgery than it looked like before surgery. So we'll go over this in just a moment. So Maya, what's happening here?
Okay. This is still
the same patient.
okay. See. And is this still the A-wire tracing? Or no?
Nope.
Okay. So it looks like
Actually, I think it might be, it's hard to say really, but I don't think it's the A-wire tracing. I think this is A pacing actually.
okay. I was gonna say, I think there's either pacing spikes or those are,
Yeah, I mean, the reason, how do we know it's not an A-wire tracing?
well, I guess almost all the leads, you can see the spikes.
Right, exactly. Usually when you're doing an A-wire, you only see the A-wire tracing in certain leads that you're attaching the clip to. So this isn't a very complicated trace. This is basically the jet being faster than your pacing rate, not being able to keep up with it. You see that the rate is accelerating and is faster than the paced rate. So you have to be careful. You always want to be faster. And eventually, after the patient was treated in this type of ECG that sometimes I know you get sent and then you forward to me, but I think we could agree that this is an A-paced rhythm in the patient. So with a pacing spike and a P wave before every QRS. So let's talk briefly about jet today, since this is the beginning of the year, and we should start at the beginning. So jet is also in some places, some parts of the world, particularly in Europe, particularly in the UK, sometimes referred to as His bundle tachycardia. And there are really two types of jet, primary congenital jet, which is thankfully uncommon, and secondary post-operative jet, which is substantially more common in clinical practice. Let's get rid of the first one. Primary congenital jet typically presents in the first 6 months of life. It usually presents at birth, and it is associated actually with very high mortality and morbidity if it's not treated aggressively early. Heart rates can be anywhere between 200 and 250 beats per minute. And remember that common SVT like ORT or AVNRT in that age range is usually faster, right? It's usually closer to 300 beats per minute. In fetal life, if this is seen, it can cause hydrops. And in postnatal life, it can cause heart failure and dysfunction through a form of tachycardia-induced cardiomyopathy. Generally speaking, if it is starts later, like beyond 6 months of age, it's usually not as fast, and it's usually not quite as dangerous. And we don't see this very often. I think Barry has a patient. I notice I've been reading a few Holters on who has this, but it's pretty unusual. Now, secondary or post-operative jet is much more common and is typically seen or presents in the first hours after open heart surgery. And it's usually seen, perhaps not surprisingly, in surgeries where there is work being done near to the His and the AV node. And typical examples would be VSD, AV canal surgery, and tetralogy, all surgeries where the surgeon is kind of forced to put lots of sutures and retraction and various different things around the area of the His and the Purkinje and the AV node system. Some risk factors in studies for the development of JET are a long bypass time and cross-clamp time, or a long surgical time in general. And that's not shocking, right? Because almost by definition, if it takes that long, chances are the surgeon is mucking around a lot near these vital structures. Age less than 6 months is a risk factor for JET, and use of inotropes at moderate or more doses in the post-op period are also risk factors for the development of junctional ectopic tachycardia. Now, what is the mechanism or the etiology? It's thought to be enhanced automaticity of the His bundle or the AV node, one or both. That's how it gets its name, His bundle tachycardia. Some people think it may represent triggered automaticity. It's unclear and practically doesn't matter in terms of clinical management. And for patients who have primary congenital JET, it may be genetic or autoimmune. And interestingly, half of patients who have primary junctional ectopic tachycardia have a maternal positive lupus anti-SSA or anti-SSB antibodies. So it's interesting how you could get heart block or you could get JET. Of course, heart block being much more common in that setting. For surgical JET, we think that the mechanism is stretch at the AV node or the His bundle, and trauma or hemorrhage in the AV node or the His bundle. Some kind of injury has clearly occurred in that area to result in that enhanced automaticity. Usually it's a fast, narrow, or I would say rather than narrow, I would use the term usual QRS tachycardia because, of course, as Maya aptly pointed out, patients with JET can develop a bundle branch block, and various different surgeries. You can have different kinds of QRS morphologies. AV canals often have unusual QRS axis and morphology because of the unusual location of the AV node and the surgery itself. Characteristics are, like all automatic arrhythmias, they heat up and cool down, so it's not uncommon that patient may come back from the operating room and be in sinus rhythm and 2 to 3 hours later be in JET. There's usually no sudden onset or offset to these arrhythmias because they are automatic, and that's important because it means that cardioversion, which is typically very effective for reentrant arrhythmias, is not useful for the management of this automatic tachycardia. And this is important. These rhythms can have one-to-one VA association or dissociation or anything in between. So you can have 1-to-1, you can have 2-to-1 retrograde, you could have no VA association, you can have 3-to-2, you can even have retrograde Wenckebach. Really, every patient is different. And so, and in fact, in the case that Maya analyzed for us, there was essentially VA dissociation, but there doesn't have to be. It's not as easy as figuring that out. You need to compare the QRS and tachycardia to sinus to rule in or out JET. And atrial pacing can be useful to compare the paced or the atrial-based rhythm to the spontaneous rhythm. So just to go over this example, this is the patient's spontaneous rhythm in an A-wire tracing. And this is the patient's atrial paced rhythm. So I'll show you again. This is the spontaneous, and this is the A-paced. Now, in truth, if you look carefully, you'll notice that although the axis of the QRS is the same, the A-paced rhythm actually is a little bit narrower than the spontaneous rhythm. So it does make one wonder if this was, possibly some kind of VT or a high VT, meaning very close to the His bundle, but not exactly a His bundle tachycardia. Practically, it doesn't really matter because the treatment is the same for both, and the hemodynamic consequences are the same. But it's useful to look at the paced and the non-paced. So when people ask me, like, what do I want in terms of assessing a patient who has JET, the most important thing, of course, is a 12-lead ECG without an A-wire. because oftentimes you can make the diagnosis there. Then you want an A-wire spontaneous. And then finally, it would be nice to have an A-paced rhythm where you're pacing at a rate faster than the actual tachycardia rate. If you have those three, you probably can make the diagnosis relatively easily in most patients. But if you had to choose one, you would want the 12 lead as the most important, plain old 12 lead. So how do we treat post-operative junctional ectopic tachycardia? Well, there are some general principles. You want to reduce adrenergic tone, and so the first step is to reduce inotropes. Sometimes we can easily do this. Sometimes patients seem to need them, and so we're a little bit caught between a rock and a hard place. But if there is room to reduce inotropes, it's always valuable in the management of people with junctional ectopic tachycardia. And even things like milrinone, which you would not normally think can cause jet, is proarrhythmic. So again, lowering the dose of the inotropes is useful. Sedation. Patients should be very heavily sedated when they are being treated for junctional ectopic tachycardia, because any adrenergic tone, even if it's from agitation, can drive the arrhythmia. And as we'll learn in a moment, use of dexmedetomidine can be useful for this. Normothermia is very important. Now, I'm not talking about hypothermia. That we'll get into in a moment. But any kind of fever at all should be treated, okay? Whether you're going to use procainamide or amiodarone, and we'll get into that in a moment, you always want to, at minimum, get the patient normothermic. Now, in pediatrics, particularly when you're a resident, right, we're always waiting to see if that patient develops a fever. And so we will sometimes, let someone get to 37.9, as, at 38 or 38.5, lots of different things happen, trigger us to do things, but we don't want our jet patients to do that. And so you want to aggressively give Tylenol or Motrin, or even use a cooling blanket to get people to normothermic levels. By that, I mean like 36, 36.5 in any patient, because that will be potentially beneficial to anybody who has junctional ectopic tachycardia. Now you also will assess the electrolytes and replete as needed. And we always do that, but I'll be honest in saying, I'm not sure I ever remember a case where that was obviously the cause of an arrhythmia in someone. But certainly it's useful that all the electrolytes be normal, more than anything, because the toxins we're about to give the patient rely upon the fact or assume that the patient has normal electrolytes. And the combination of, for example, hypokalemia or hyperkalemia or hypomagnesemia with some of these agents could be dangerous. Now, there are generally, I would say, two major approaches to the management of junctional ectopic tachycardia, and it really depends on which school you come from. They both work reasonably well. The first one, which a lot of you know I tend to favor, is cooling plus or minus procainamide. And so in this approach, one would cool the patient to approximately 34.5 degrees. Now, it's very important that when you're doing this, that there be either a continuous temperature probe, typically a rectal probe, or that you're checking it very frequently, because particularly in small children, it's very easy to overshoot and make somebody too cold. And although that will be good for the rhythm to a degree, if you go a lot below 34, you severely increase the risk of developing VF. So you have to be very careful when you're shooting for 34.5. You have to make sure you're not below that. So 34.5 to 35 degrees would be an ideal temperature for when we're talking about cooling. And when a patient is cooled this much, they will shiver naturally. And so they need to be very aggressively sedated. The most common agent that we use today is dexmedetomidine, which some people view as a therapy for jet. But if the patient cannot be sedated enough so that they're not shivering, then the use of muscle relaxant should be strongly considered. And it used to be that everybody thought that you had to use both, but now I think we're able to sedate usually enough with the dex and a little bit of narcotic that the patient is usually not moving. And then you would atrially pace at a rate that's faster than the jet if it's feasible. Now, If the rate does not fall to an acceptable level with just cooling, then we would give procainamide. And typically what we do is we give 5 per kilo boluses over about 20 minutes. And I would say generally we give it up to 4 times as needed. And during that time, we would also start a drip at usually at 20 mics per kilo per minute. Once the rate has fallen, we would then atrially pace. And you should always have volume ready for hypotension due to vasodilation. We don't see as much vasodilation and hypotension when you give it in 5 per kilo boluses. If you look in like most reference books, you'll see that they typically say the bolus dose is 10 to 20 milligrams per kilo. But if you give it in these smaller aliquots, you'll usually have much less hypotension. You just have to sit at the bedside and determine whether you need to give more. And it would be unusual that 1 dose would be enough in my experience. The other general approach is that of amiodarone. And for giving amiodarone, we would give 5 milligrams per kilo as a bolus typically over 45 minutes. And you're going to carefully monitor the patient for hypotension or impending cardiovascular collapse, which is seen in about 2 to 5% of infants who receive this agent, which is one of the reasons why I'm not a huge fan of this approach, if not necessary. Some operators will give amiodarone in smaller doses in similar fashion to the procainamide. They might give 1 per kilo over 5 minutes, wait, see if there's a response. If not, give another 1 per kilo and give it up to 5 or 10 times for effect. So various different approaches. People who do that often tell me that after 2 per kilo, they see good response. I have not personally observed that, but certainly possible. And again, once the rate has fallen, you would atrially pace or AV pace if needed faster than the now slower junctional rate. I would make the argument that one should not use IV amiodarone unless there are present ventricular pacing wires, because in some patients, amiodarone can cause heart block or second-degree heart block, particularly in someone who already may have a minor injury to the node. It may hamper your ability to conduct at faster rates. It might prolong your Wenckebach cycle length. And so if you can't V-pace and you can't conduct at rates, say, over 120, then it may be very challenging to manage such a patient. So I would generally say that I would not use amio to treat most arrhythmias, but particularly jet, unless you knew you had a functional ventricular wire. Normothermia, as I mentioned earlier, is good for these patients, but importantly, and perhaps the most important thing, hypothermia is not required when you're giving amiodarone. Procainamide, you do need to use hypothermia. It does not work on its own. But for the use of amio, you don't need hypothermia, and that is one of the main reasons why some people favor it, because in theory, if you're not making somebody hypothermic, you do not need to, you can extubate the patient faster, right? Because you don't have to warm them up, which typically takes a day or two. There's a shorter ICU stay, possibly. And also, of course, cooling somebody enhances the possibility of getting infected for multiple reasons related to being cooled itself, as well as just the length of time you're in the ICU, which, of course, enhances your risk for infection. So that would be the main reasons. I will tell you that if you critically look at the literature, the evidence for amio working for this consistently is actually pretty small, and the incidence of serious side effects is something in the range of 20%, whether it's phlebitis, very bad phlebitis, hypotension, etc. So it does work, but it doesn't always work, and one needs to be aware of that. Now, some general principles. The same approach will work differently in different patients. In some patients, if you have jet at, say, 180, pacing the atrium at 190 will improve the hemodynamics substantially. But in other patients, pacing the atrium at 190 will worsen the hemodynamics, and being in jet at 180 is actually better. And so, you really need to make an intervention and carefully observe your patient at the bedside in order to see whether your individual patient benefits or doesn't benefit from it. You'll hear people who'll say, oh, I I don't even use meds. I just pace, faster in the atrium. It always works. That's not true. And everybody is different. And then the doses that are necessary will vary wildly. Some need very little amiodarone, as I mentioned, or proc. Others need a lot. And very importantly, in my view, all patients who are in JET should be treated because it can worsen in any patient. So sometimes I'll be asked the question, if somebody is, at 170 but has reasonable blood pressure, it is still urinating, is it okay to just not treat it and watch it? And I would say no, because you just don't know what direction it's going to go, and the effects can be insidious. And so I would say that in anybody who has any hemodynamic embarrassment from JET, treatment should be used. And then again, Precedex is generally used in all patients in the present era in post-op patients, but in particular, for patients who have JET, it could be considered an ancillary treatment for JET, and aggressive sedation is always useful in all approaches for the treatment of this arrhythmia. And again, assessment should always include both a 12-lead ECG and an A-wire recording, and if you can, an A-paced 12-lead also would be very useful, as we discussed. Some alternative approaches. Some centers are starting to use ivabradine, which is actually an enteral agent that has been demonstrated in some smaller studies to be effective for the treatment of JET. There's a paper that came out of a group in India, which they had a fairly large number of patients in whom this agent was used with good effect. I think it has not caught on in the US because it's a novel agent, but more importantly, because it's enteral. And I think there is concern about variable absorption in somebody who's in low cardiac output in the postoperative period. That said, there are some nice descriptions of its use where there's an appearance of improvement and help. And then IV sotalol, another agent that seems to be effective for the treatment of JET. The literature on this is pretty paltry. Most case reports of IV sotalol include all patients that they treated with IV sotalol. But if you drill down and look at the people who have JET, it appears as if it's effective. One of the big advantages, at least so far, is it does not appear as if IV sotalol carries that risk of cardiovascular collapse that we see with amio. And so it may be that IV sotalol becomes more commonly used for this medicine, for this arrhythmia. But we'll have to see. As you know, both amio and proc work fairly well for this, so someone's going to need to do a study to really prove that it's effective. And sometimes when new agents come out, papers are written suggesting how great they are, and then later on we determine that it wasn't as great as they thought. And the classic example is amiodarone, where initial papers suggested it was incredibly effective for everything, and over time, I think we've come to realize that although it is a good agent and it has saved many people's lives, it is not good for everything and does not universally work all the time. Okay, any questions about JET in general? Anything we've talked about? Is that useful for the audience today?
Yes, it was very useful.
Okay. Thank you for that. I'll take that. Okay, we'll do one more tracing today that is unrelated. This is a 3-year-old who had an ASD repaired 2 weeks ago and comes to the office for follow-up. So what is this rhythm, and what would you do about this? So let me ask Dr. Kitoki what she thinks about this.
Good morning, Dr. Paz.
Good morning.
So there's a P wave. I'm looking at 1, 2, 3, and so there's a P wave in front of the leads, in front of all the QRS complexes, and the PR interval has increased from the one to the other.
Right. It's a bit of an unfair question, Kitoki, because there's no lines on this EKG, so I apologize. But you're right. The PR interval definitely seems to be longer between the first and the second beat.
And
what do you think about this one here?
it's even longer, so it's like it's increasing progressively.
It's actually infinitely long, right? There's no QRS after this.
Yes.
Right.
Yeah. So I would think
So
this
how would you
is
describe this rhythm?
so
Is it first degree or third degree?
this is a second degree.
Right, correct. It's a form of second degree heart block. Is it Mobitz 1 or Mobitz 2, do you think?
This is like progressive increasing and there's a drop. So I would think this is Mobitz 2.
Well, Mobitz 2 would be, well, Mobitz 1, right, is where you have a continuous prolongation in the PR followed by a drop. So the first 3 beats might be suggestive of that. But then here, we see some P waves that really look like they should conduct, right? I mean, first of all, this probably is junctional beat because this PR is very short, right? It's so short that I don't think at this P wave we can assume conducted to the QRS. Hold on just a moment, I'm sorry. However, this P wave and this P wave also is, too close. This P wave, right? I don't know what this rate is because I gave you a tracing with no lines, but I think we could argue that if this is 25 millimeter speed, this is probably a rate of about 100 or so. And in a 3-year-old, a P wave should conduct at a rate of 100. Similarly, this is even slower. Maybe this is a rate of 90 or 80. So I think the way I would describe this tracing, and different people would call it different things, but I think I would call it high-grade AV block, a high-grade second-degree AV block. So Mobitz 2 block. And so if I saw this, and if you saw this in the office and somebody who had an ASD repair the week prior, patient says they feel fine. This is news to them when you tell them this. What would you do about this, Katoki? Any thoughts?
I would admit the patient and monitor it via like monitor the rhythm via telemetry and see what's going on.
Yeah. I think some of your friends may have helped you there, which is good. No, for sure. I mean, because remember, we've talked about this, that post-operative heart block is potentially life-threatening. We spoke a few weeks ago, actually a few months now, that in the post-operative setting, high-grade AV block can be associated with Stokes-Adams attacks and sudden death. In fact, in early literature, in an era when we could not routinely pace people following open heart surgery, if you got heart block, there was about a 50% mortality at 1 year in patients who have heart block following heart surgery. Now, heart surgery is done differently today. The degree of injury to conduction tissue may be different because of newer techniques of surgery, but the bottom line is, in the present era, if we see someone who has high-grade AV block following congenital heart surgery, that patient is at least in theory at risk for sudden cardiac death. And so they need to be observed. And I agree, we would watch this rhythm in hospital in order to figure out if there is any, if it's recovering, if it's getting worse. Because if it were to remain at this level, then this patient would need a pacemaker. Some people have asked the question whether anti-inflammatory agents like steroids, for example, would be of any benefit in a patient like this. The short answer is nobody really knows. For sure, there is anecdotal evidence that in people who have catheter-based injury to their AV node, whether during ablation or with stiff wires, sometimes giving steroids appears to be helpful, at least anecdotally, no real strong evidence in large series to my knowledge. But in the post-op period, again, not really strong evidence one way or the other. If the surgeon allowed it, it wouldn't be unreasonable to try it, but I would not hold out a lot of hope that it would make a difference. Okay, I think with that, we'll stop for today. Hope you guys found that helpful, and I hope everybody has a wonderful week ahead.
Thank you.
Thank you.
Thank you. Bye-bye.